A middle-aged man presents with evaluation of his right dominant hand. He complains a deformity involving small and the ring finger with loss of function, especially the motor skills. He relates a problem that he had a couple of years back. He had a laceration at the level of wrist joint which was sutured. He reports numbness of the small and the ring finger as well. He denies any radicular symptoms in the contralateral hand. The obvious clinical suspicion would be an ulnar nerve injury in this case. At physical examination, there is atrophy of the hand involving the intrinsic musculature. The small and the ring finger are positioned in a claw deformity. All the passive interphalangeal joint extension is present and the joint is supple. The patient has difficulty abducting and adducting his digits. His flexor digitorum profundus function at the small and ring finger is intact. Sensory examination further reveals tooth-point discrimination reduced in the small and the ulnar half of the ring finger. You went on to diagnostic assessment and electrical studies were obtained which reveals a complete ulnar nerve lesion at the wrist joint. No innervation potential is present. The thinner musculature electrical activity is normal and there are no evidence of peripheral neuropathy or radiculopathy. When we have this case in our mind, the differential can be multiple. A brachial plexus injury like upper and lower plexus injury can be one possibility. Cervical root irritation is another. Peripheral nerve dysfunctions like Charcot-Marie-Tooth disease should be also thought of. Ulnar nerve tunnel compression, cubital tunnel compression, Pancoast tumor, tendon laceration and laceration at the level of ulnar nerve at the wrist are some of the differentials. The differential of a claw deformity of the hand with loss of sensations ulnar distribution is somewhat limited. One assumes a lesion of the ulnar nerve or possibly the lower cervical nerve root lesion C8 and T1 or inferior brachial plexus lesion. Cervical nerve root compression typically results in neck pain with radicular symptoms down the arm. Weakness and atrophy would be expected in the thinner and hypothenor musculature both together, as both are innervated by lower cervical and first thoracic nerve roots. A lesion of lower brachial plexus, like for example Pancoast tumor of the lung, would result in similar symptoms. The ulnar nerve is most commonly compressed at the elbow at the cubital tunnel or at the wrist at the ulnar tunnel. Intact function of the two ulnar flexor digitorum profundus would point towards a more distal lesion than the lower forearm lesion. Lastly, one must rule out the peripheral nerve dysfunction like Charcot-Marie-Tooth disease or hereditary motor sensory neuropathy. Intrinsic atrophy with or without sensory loss may be seen in saragomelia or motor neuron disease like amyotrophic lateral sclerosis. The typical result is symmetrical disease and not unilateral. The history and physical findings collaborated along with the electrical activity in localizing a nerve lesion is important and also to rule out generalized disease process. The diagnosis here is a lower complete ulnar nerve palsy. The ulnar nerve innervates the four dorsal interossei, three volar interossei, and two ulnar lumbricals, the hypothenar muscles, and typically the deep head of the flexor pollicis brevis. A surprise sensation of the small finger and the ulnar half of the ring finger. A claw deformity develops due to the imbalance between the intrinsic muscles and intact extrinsic musculature. The claw deformity is more pronounced in the ring and the small finger due to the intact index and the middle finger lumbricals, which are innervated by the median nerve. Clawing is more significant in the lower nerve palsy than the lesion at the elbow due to the intact flexor digitorum profundus tendon of the ring and the small finger. These tend to accentuate the flexion posture of the interphalangeal joint. The ulnar nerve dysfunction is quite disabling. The intrinsic muscles are responsible for simultaneous flexion of the metacarpophalangeal joint and extension of interphalangeal joint. that is intrinsic plus position. Although full finger flexion and extension is present, with intrinsic loss tend to roll up during flexion due to asynchronous motion of metacarpophalangeal and the interphalangeal joint. What it means is the metacarpophalangeal joint flexion does not begin until interphalangeal joint flexion has been completed. The interphalangeal joint extension requires contraction of the extrinsic extensor tendons, i.e. extensor digitorum communis. This leads to MCP joint hyperextension and contribute to the clawing. The ability to place the hand around objects such as glass or doorknob is lost. These activities require the intrinsic plus posture. All fine motor skills that require simultaneous metacarpophalangeal joint flexion and interphalangeal joint extension, such as writing or threading a needle, are similarly impaired. Lastly, pinch and grip strength are markedly diminished due to loss of interosseous and the hypothetical muscles. One would argue that the treatment should start with a non-operative management or non-surgical treatment. Conservative management for ulnar dysfunction is quite simple by placing an external splint to block clawing of the digits. A lumbrical bar splint is commonly utilized for this purpose. It is a static splint, usually made by the orthoplast by hand therapist, that fits around the dorsum of the metacarpal heads and proximal phalanx. It does not improve grip strength or integrated metacarpophalangeal or interphalangeal joint motion. It does, however, block metacarpophalangeal joint extension of the ring in the small finger, thereby correcting the clawing deformity. This enables the extrinsic musculature to fully function for the interphalangeal joint. It also prevents fixed proximal interphalangeal joint contracture from occurring. Now we go towards surgical management. A compressive neuropathy of isolated nerve distribution is identified and a decompression of the nerve is indicated. Unfortunately, in the ulnar nerve transections, full recovery seldom occurs following repair. This is due to the mixed nature of the nerve, as well as a complex motor function and innervation which the intrinsic muscle hand has. Recovery, especially guarded in older individuals in high lesions and in nerve loss requiring grafts or reconstructions. Furthermore, motor end plates cannot be functionally innervated years after paralysis. In these settings, tendon transfer is one of the ideal options to restore ulnar nerve function. There are many surgical procedures described to treat patients with intrinsic muscle paralysis. Tendon transfer are described to correct the claw deformity and integrate metacarpophalangeal and interphalangeal joint motion, improve the grip and pinch strength, and restore lateral deviation of the digits. All require a motivational patient, fully passive mobility of the digits. The choice of transfer depends on the age, need of the patient, ability of the patient, and the donor availability and the level of palsy. In our case, we decide to a simple transfer to correct the clawing deformity and restore the synchronous function of the fingers. This was thought to be most appropriate. Level of grip strength was not one of the complaints, and thus a transfer in role of wrist tendon was not chosen. The only way you can improve a grip strength is use wrist motor unit tendon, which add power to the hand. This, however, requires the use of free tendon grafts to augment tendon length and thus is more complicated procedure. In our case, a Stiles bundle transfer was chosen, which utilizes a flexor superficialis tendon to restore metacarpophalangeal joint flexion and interphalangeal joint extension and redistribute the balance between the forces in the hand. The FDS is excellent amplitude and force with little functional mobility as a donor. As this patient had low ulnar nerve palsy, the only ring in the small finger clawing, a single FDS tendon from the middle finger was transferred. Through a palmar incision, FDS was harvested and split longitudinally. These were then passed through the lumbrical canals palmar to the MCP joint and sutured into the lateral band of the extensor mechanism of the ring and the small finger. When the wrists are passively flexed and extended intraoperatively, the ulnar digit no longer assumes a claw posture. Postoperatively, the patient was placed in a short-arm dorsal blocking splint with the wrist in 20 to 30 degree of flexion and MCP joint at 6 degree of flexion for 3 weeks. Active flexion and extension of the fingers were allowed within the limit of the splint. The hand-based lumbrical bar splint was then worn for additional 2 weeks. At 5 weeks postoperative, the patient regained synchronous digital flexion and extension without clawing. The functional use was encouraged thereafter.